Welcome to Whiteboard Learning Low Tech Blood Pressure number 2, second session. We're all basically going to focus on low blood pressure, hypotension. If you remember our formula, it's mean arterial pressure equals cardiac output times systemic vascular resistance, right? So what the heart can pump out versus the resistance it pumps against in the arteries. Those things are determined by vasodilation, vasoconstriction, and cardiac output by stroke volume times heart rate. And stroke volume is determined by how much comes to it. So that's going to be important. That's volume, how much comes to the heart to get pumped forward. And after load, that's a little bit more important for when we're dealing with hypertension. So we probably won't talk that much about today. But also contractility, which can be affected. So we talked about in session number 1 a few of the things that can affect blood pressure in causing it to be lower, and that could be lower cardiac output, either lower heart rate, arrhythmia, heart degree block, a first degree heart block, or a lower stroke volume with a lower preload, poor contractility, or an increase in afterload pushing against a larger volume. And also you could have hypotension from a low systemic vascular resistance. So vasodilation in the periphery. So all the blood is pooled in the periphery and there's not much to push against. So the pressure can't be maintained. So let's talk about anesthesia a little bit. So under general anesthesia, we are usually using multiple agents. We have some IV agents and we have some gases, and we have definitely got a kind of a plethora of drugs that we can use, but we also have some other drugs that when we're thinking about IV, we can talk about induction drugs, or we can talk about pre-meds, and we can talk about other drugs that we might add that are perioperative types of drugs, like we might give certain drugs if we're removing a mast cell, or we might give steroids if it's a brachycephalic. So there's other drugs we might give, but they aren't contributing necessarily to the general anesthesia. So for general anesthetic gases, most gases lower blood pressure. And so that's something to think about when we're starting out. We try to not use all gases. And so some of what you've learned over time is that we don't induce with face masks anymore, although sometimes that might be a good idea, like with sevoflurane. We usually use multiple agents. Well, those agents can lower blood pressure. So opioids and propofol, and also things, a little bit of Valium, those type of drugs, but mostly it's the opioids and propofol that will lower your blood pressure right away. And we think about certain pre-meds like the opioids. Acepromazine can lower blood pressure. And generally, as we're sort of thinking about our patient, we make a choice in the beginning about these drugs based on our patient, because certainly we're going to expect some problems based on our patient, and that is true in human medicine. There are patients that are more predisposed to hypotension under anesthesia because of certain factors, and what they figured out makes sense for human medicine, for veterinary medicine as well. So we have age, we have ASA, the Anesthetic Society, their classification, so greater than 3. And if you aren't sure what the anesthetic classes are, it's a good time to go back and review them. It's basically putting you on a severity of illness scale. And 1 is like a normal puppy spay type situation. We also have the E, right? So E for emergency is like your GDV. So already they're a little bit in trouble. And then other things might include, if you are starting out, hypovolemic. So let's say you are dehydrated. You might be a farm body. You might be a polyuric pet. So you're making too much urine, and so you're already a little behind, because then somebody fasts you in the morning, or you're too scared to drink out of your water bowl. And some of those patients you might put on fluids before you do surgery, but that would be a renal failure, cat or dog, and that might be a diabetic, It might be a thyroid PET. So you have to think about your patient before you go to surgery, that some of these patients might be sick. And then you got to think about the sepsis, right? Septic patients are definitely more prone to hypotension under anesthesia. The other thing that seems stupid to say out loud is like if they're already having hypotension. So if you have a patient who comes in for your service for anesthesia, you should have a starting blood pressure. It shouldn't be under anesthesia the first time you get a blood pressure. So you should take a blood pressure and know the blood pressure before you even get on board. So some of these problems can be predicted by looking at your patient and saying, oh, okay, what are the factors this patient has and how can I be prepared? Or how should I prepare the patient ahead of time so I can avoid problems? And then you have to also think a little bit about the problem other than sepsis. We talked about this a little bit last time, but if there's a lot of abdominal disease, like a GDV or fluid or some sort of cardiac disease, you might have a presumptive issue already with contractility or with medications that are on board, or a respiratory disease. You also have to think, what am I doing to those things, those areas? So am I doing a thoracoscopic procedure where I'm blowing up the chest, or am I opening the chest with an open thoracotomy and I'm letting the lungs shrink? Am I going to be doing a liver mass, a large liver mass, and I'm going to be up near the diaphragm, and so I might nick the diaphragm and cause a pneumothorax? So, and as an anesthesiologist, you're sort of thinking about what is my surgeon doing? Are they working with an adrenal tumor and they could nick the vena cava at any point and things could go south, right? So you got to think, what is my patient? Who are they coming in? What are they having done even before you have to deal with the hypotension under anesthesia? So the most common time for hypotension under anesthesia is at induction, and that is usually because you're creating such a sudden change in their status. And the worst agent to think about are some of the propofol, high doses, and then fentanyl. And that would be the same also for other high dose opioids. And so first thing to think about is monitoring your pet very closely while they are being induced for blood pressure issues, so that you know when they're happening at induction. And under general maintenance of anesthesia, usually the problems are of volume loss or of your heart not working well. Let's say if you have a septic patient and their contractility goes down, or there's a lot of drugs on board that are lowering their plane of anesthesia. Because as this is, alive, and this is death, and here is anesthesia, right? So this is controlled death. And so as you get deeper anesthetically, you get closer to death. So you really have to know that under some circumstances here, you are creating a situation where you are going to be prone to hypotension. The other thing is mechanical ventilation. So mechanical ventilation creates a situation where the pressure into the chest, that you're driving into the chest, into the patient, and here's the set of lungs. This is a terrible picture. So the pressure going in is actually going against the chest pressure, and that's going to shrink the heart. And that's going to make it harder for the heart to pump effectively. So mechanical ventilation is a savior, but it also can create a situation where you have hypotension. So what do we do about those things that happen? You're going along and your pet gets hypotensive. Well, you're going to pick up little changes. So maybe if they were 120, now they're 100. And you got to start having a conversation with your surgeon, right? Hey, what are you doing? Are you manipulating something? How much blood loss is in there? Looking in your canister. So first step is think kind of communication. And then observe. So you want to look at your cuff. Don't spend a lot of time redoing all your cuffs. If they were working and now they're not, and nothing has really changed, don't spend 20 minutes while your pet's hypotensive just playing around with your equipment, right? So look at your equipment. What else is happening? Is the heart rate dropping, or is the heart rate up? Is your patient CO2 rising as well, or is it low? A low CO2 could mean they might be about to arrest. A high CO2 means you're not ventilating them enough. They're deep, they're not ventilating themselves enough. So you might get an idea just from looking at these things that, is your patient responding to volume loss with a higher heart rate? Is there an arrhythmia that you might need to control? Or is the heart rate going down and the CO2 rising and your patient's blood pressure is lower, and that death might be imminent, but you also know maybe I'm too deep. So the second thing is that you're going to do is probably lower your anesthetic. And that might be all of them. You might have a CRI that you drop a little bit. That might be your ISO or your SIVO. And you can get down a little bit as to keep your anesthesia going. And try that first. And then after that, you might have to consider, if I'm looking like I'm kind of not responding, I might want to start with an anticholinergic, or what you also call parasympatholytic. So your parasympathetic system is off, so it's lysing. That word was wrong. Lysing, and that's atropine and glycopyrrolate. Those are generally my first drugs that I will give, other than some fluids. And so fourth might be some fluids, right? If you think your patient is getting behind, you might give a little fluid bolus, and that might be only 3 to 10 mils per kilo, depending on your patient, or it might be more if you see your suction bucket is getting very full. And so it's your first four things, and they're not that hard to do as you're noticing that the blood pressure is changing, is to communicate to the doctor, find out what's going on, also letting them know what's going on, observe all your equipment, check your patient's vitals, where are things going with their CO2, their pulse ox, their heart rate, the EKG, and then also start lowering your anesthetics, maybe even wean your patient off of mechanical ventilation and hand bag them if you're starting to notice trouble with your other parameters. And then you're breaking out the anticholinergics if you haven't already given atropine and glyco. And that might help all right there. Try a fluid bolus. You should be ready for all those things. Step number 5 is the step that everybody gets a little bit worried about, and that's when do you break out a vasopressor or an inotrope. Now, you may have heard both of these terms. So an inotrope is a medicine that helps the heart to pump better. So that's focusing on contractility. There's also the word chronotrope, and that helps the heart beat faster. And these are usually classes of catecholamines. Catecholamines are your stress hormones, right? So those are epinephrine. So one thing atropine does is also increase the rate. And it can help, therefore secondarily help the heart to pump better because it's more efficient. But so these are somewhat different ways to affect these. A vasopressor is actually a medication that could be an inotrope too, but is also focused on systemic vascular resistance. And it is increasing systemic vascular resistance. And it might be arterial increase of resistance or a venous or both. And a lot of those medications, the catecholamines, have different receptors. And so you'll hear about inotropes as being like beta 1 and beta 2, and vasopressors being alpha 1, and more of the catecholamines. But there are also agents that don't work by those mechanisms. But the common ones do. So epinephrine works mostly by increasing systemic vascular resistance, increasing contractility, and increasing the heart rate. You know that from CPR. And then you have another compound, dopamine. Now, dopamine generally works more to give the same effects as epi, but a little less of inotrope and chronotrope than epi, but can be a vasopressor. Not as strong as epi and is not given as a bolus, but you can start a dopamine CRI to increase the pressure. Norepinephrine is a derivative in the body of dopamine and epi. And norepi works more just to work on systemic vascular resistance. And then there is vasopressin, and that works by a different receptor to increase systemic vascular resistance. It works on the vasopressin 1 receptor. So if you've done all of your other things, a small bolus, it did or didn't help, you've given the atropine, glycopyrrolate, you've turned down your drugs, and you're still worried, within about, I would say, 10, 12 minutes, you should be deciding if you need a vasopressor's help or an inotrope. Now, if you do think it is contractility mainly that is your problem, like you have a Doberman who has trouble with pumping its heart, you may choose dobutamine. Dobutamine is a catecholamine type drug that works a little bit more toward contractility and less on vasoconstriction. And so it helps a little bit more with contractility. So you do all of those things, and you start this vasopressor, and nothing happens, and it's 10-15 minutes. What do you do? Well, the good thing about vasopressors is they work very, very quickly. As you know from CPR, epi given as a bolus, if you end up having to give epi, given as a bolus is going to work within seconds, within 10 to 20 seconds. And the effect can last 5 to 15 minutes. If you turn norepi or dopamine or whatever you want to use on, you should see an effect within 10 to 15 minutes. And if you do not, you increase. And so if I start norepi at 0.05 micrograms per kilo per minute, I will double that if I'm not seeing the effect I want. And I will be pretty aggressive about it. And why are we aggressive about these sorts of things? Well, hypotension can lead to organ death. And that's what we're most worried about. And it's not the organs you sort of think about. We think about brain. Brain is relatively preserved. Your brain is pretty good. Here's my faux brain here. Is pretty good and gets most of your blood supply anyway, especially in a prone laying down position. But the organs that don't get very good blood flow, if your blood pressure drops, are the kidneys, GI, and liver. And when blood starts to just sit there, so if blood isn't flowing well out in the capillaries, you're going to become coagulopathic very quickly. So not only do you get ischemia, your blood becomes stagnant and you start to get coagulopathic. So hypotension is very bad, and hypotension is thought to increase the shortness of the life of your kidneys, and your gut might start to slough and have stasis. So we definitely want to avoid it. When it gets worse, you're going to get the effects to your brain for sure. It might kill a few brain cells or have a patient who doesn't want to wake up. So in summary, under anesthesia, communicate with your surgeon, find out what's going on, check all of your monitors, consider atropine, consider turning everything down a little bit as much as you can, consider then also giving a fluid bolus. That fluid bolus might also include blood. If your patient is losing a lot, just go right to blood. Don't mess around too much. And then also the next thing is vasopressors. And that decision should be made in the space of about 5 to 15 minutes, especially if you're waiting to see if your fluid bolus is going to work. You need to get that patient on pressors as soon as you can. And that's why we have some calculators that help you make those calculations ahead of time, right? So predict that your patient might have a hypotension episode by doing your homework ahead of time. All right, I hope that helps.